Good afternoon and welcome. I am Alicia Burkmeyer. I serve as Chief Health Management Officer for Arkansas Blue Cross and Blue Shield. I'm in my role, I really look at working on finding available access to care for people, for our members, high quality care for our members, and through that, ensuring, especially the people in our rural parts of our state, that they have access to care. In Arkansas, the majority of our counties, out of our 75 counties, are classified as rural counties. And so we truly live every day the challenges that we see in getting access to care, getting high quality care to all the people that live in Arkansas. In the Arkansas Blue Cross, we're a non-for-profit organization, and we have several segments that break out our business through our government programs, including the FEP, the Medicare Advantage, and the exchange. And then we have our commercial, and then our self-funded or ASO business that we cover our members throughout all states. This is not one problem that's just for a particular segment or market, but it really hits across all. So please join me in welcoming, and I'm very honored to be a part of this panel with such esteemed professionals that we're going to spend some time today talking about rural health care, the challenges, but also we're going to talk about opportunities through some of the great leadership and work that the Centers for Medicare and Medicaid Innovation has done. So I've got Dr. Sean Martin, Dr. Angelo Simpoli, Aratab Bedwar, and also Aaron Wernham. And you can see their full bios in the materials, and we really want to spend the time in hearing from them and discussion, so I'm going to move right on to the questions. So first of all, thank you all for joining me, and I'm excited to have this discussion here today. I'm very passionate about rural health care. We had the fortunate opportunity in April that when I had talked to John Bloom about coming to visit Arkansas, I said, if you want to see rural health care, come to Arkansas. And when I spoke with him and he said, hey, Alicia, I'm going to come April the 1st, my first thing was, this is an April Fool's joke. They're not really coming. Much to my surprise and enjoyment, we had a wonderful team. Liz Fowler and John Bloom and Kate Davidson and several others joined us for 2.5 days. We'd go from 7 in the morning to 7 at night. We visited with the Fayetteville Police Department that has social workers integrated. We visited with hospitals, with employers, and many types of providers. We heard through that an opportunity, and then certainly I had the fortunate opportunity to join CMS in some of the rural health care hackathons, and it was such a pleasure. So I'm going to start with the first question with you, and let's see here if we can get my eyes off to that age and stage where I have to do the reverse here. CMMI recently hosted the series of 3 rural health hackathons and published the report just recently on rural health care. Can you tell us some more about what you learned from the hackathons and the path forward for CMMI?
Yeah, absolutely. Thank you so much, Alicia. And that trip to Arkansas was part of the inspiration, as well as trips that we took to Texas earlier this year. And they were opportunities to talk with providers and patients and really just community leaders who are very well versed in the challenges facing rural healthcare, and who were able to highlight for us that what still remain are questions about how to solve for those really thorny issues. And I was able to join the last hackathon, the 3rd one that was in Wilson, North Carolina, and to hear directly from folks on the ground who every day are working to push forward rural health care. And I think there were similar conversations that were had at the 2 previous ones. And so when we came back, we really wanted to be able to pull together what we'd heard. And the white paper that the Innovation Center released earlier this week really does that. It captures the learnings from Bozeman, Montana, from Dallas, Texas, from Wilson, North Carolina. It demonstrates how the Innovation Center can take those learnings and pull them into both our current and future models. And then it summarizes the themes that we heard across all of those hackathons and lays out a path for going forward for the Innovation Center. And just a little bit more on the key themes that we heard. In the paper, we tried to order them around the key challenge areas that we set out in the hackathon. So the first key challenge area was around care delivery. And some of the themes that we heard back were around the need to think about financial sustainability of the value-based care models that we're establishing, particularly in communities where the participants in the models, hospitals, sites of care, they are also the main employer and the main economic hubs in these communities. We also saw themes around collaboration show up, specifically the need to collaborate between CMS and rural providers, and to do that early so that there was a better chance of alignment between the models that we were testing and the local priorities and capacity for those model tests. The second challenge area that we ordered the themes around was access to care. And what we heard there in terms of themes were desires for us to think about the challenges around providing whole person care in rural communities and the difficulties in ensuring that we are able to deliver in rural communities the entire range of care that an individual might need. And related to that, there were themes that came up about the really important role in rural settings that community-based organizations and individuals play in helping to plug some of those gaps in care delivery, and a desire for us to think about whether there were opportunities within the models to capture and to potentially reimburse for some of that care delivery that was happening outside of the system. The last challenge area that we oriented around was one that was really popular across all three of the hackathons, and it was workforce. We heard consistently across all of the hackathons that there were challenges around workforce. And just to give you a sense of some of the things that came out of there in terms of themes, there was a desire to look at ways to do more recruiting locally, finding ways to recruit folks to support rural health care locally. And then as we recruited, to think about how we retain and continue to develop those individuals. So finding ways to do that, and then growing a pipeline of talent. So are there ways locally to ensure that there is a healthy pipeline of individuals who can serve as health providers, whether that is through creating partnerships with high schools and trade schools, or developing career development programs and continuing education programs, but really thinking about the opportunities that we had locally to support and develop local recruitment for healthcare delivery. And then in terms of the path forward, I'm just going to highlight a couple of the areas that we're currently exploring. There's obviously going to be more to come. We're early yet. The first area that the Innovation Center is looking at is thinking about how, within the current models that we have, whether there are opportunities for us to create new chances for rural healthcare providers to join them. And so this week we also announced a new opportunity through a request for applications for up to 8 hospitals to join our rural community health demonstration. So it's a chance for 8 hospitals to join an existing model. We're also looking at our Making Care primary model and thinking about whether there are opportunities going forward to add rural health centers to a potential second cohort in 2027. So again, looking at a current model and thinking about whether there are ways to include rural providers in that going forward. And then as we are contemplating a next generation F-CHIP model, thinking there as well about expanding the participation of critical access hospitals in that next generation model. Another area that we are thinking about is rural-focused model design elements that we can incorporate into or make a part of both our existing and our new models. So thinking about whether there are things we can do related to the benchmarking or Benny attribution or quality measurement that will make the models easier for rural providers to participate in, more attractive for them to join. We're also looking at the existing waiver authority that we currently have and thinking about whether within that existing authority, whether there are opportunities to use that going forward to create additional flexibilities related to workforce and site of care requirements. And then the last area I'll highlight before I turn things back to you, Alicia, is around seeding innovation. We're looking at and thinking about whether there are ways for the Innovation Center to help support innovative approaches to trying to tackle some of these thorny issues that remain in rural healthcare, whether that might be something like a challenge grant that allows us to try to tackle and pursue solutions to challenges with coding or billing, but really continuing to think about innovative solutions that can support creative thinking in that space.
Thank you so much for sharing that, and thank you for all the good work that you're doing. I think I was so impressed with the current staff that the willingness and openness always to listen to the community, to get out, to listen to anyone that was willing to speak, the patients, providers, and others. So that's really important. I see that through these models and these new opportunities you're discussing. Thank you. So now that we've heard from CMMI, I want to ask a question for the rest of you to respond to. Can you share a bit more about your organization's recent efforts to advance accountable care, value-based care in the rural areas that you work with? What's worked and what's been your challenge? And so, Angela, I'm going to start with you down at the end there, and then we'll come this way to Sean and this way.
Good, thank you. So our approach to the rural environments in our network have been something that we refer to as a combination of medical neighborhoods associated with what we call accountable communities. And so that medical neighborhood model is where we take the assets of our local health systems and extend that out into those rural communities. That may be mobile clinics, that may be telehealth, that may be paramedicine programs, community health workers, and those are assets that the delivery system can provide. And then on the flip side of that is what we call accountable communities, is providing leadership, organization of the community assets, the community-based organizations, the local county and state agencies where we partner together, including EMS, et cetera, where we may not be funding those, but we're helping with that organization, helping with that clinical integration across those rural environments so that we're not just implementing a program, but we're trying to figure out an ecosystem for those areas that actually provides those patients with the care they need. And that's worked very well in a couple of different environments that I've been in. So,
excellent. Thank you very much. Sean?
Yeah, thank you. I think to start, probably give you a little context on Oscar Health, which I think will give good context to my answer. We are a relatively new health insurer focused on the individual population. And we were really founded out of the premise that I think we've heard a lot about today, which is that better leveraging technology, we do believe can increase personalization, access, and affordability for individuals across the ecosystem. Given the rates of un- and underinsurance in the rural community, it's natural then for us to play in that space. And when I think about accountable value-based care, again, consistent with what we've heard in several panels today, I really think of there being three key elements. The first is you have to have care delivery transformation. And then the second is you have to have payment transformation that enables that care delivery transformation. And then the third is I believe you need an enabling technology layer between those. And my experience is that you need all three for it to work well. It can work if some are a little more mature than others, but really you want all three. And when you think about rural communities, I think they have real foundational challenges in all three. So we had to ask ourselves, what's the role of a payer in helping rural communities overcome some of these challenges? And where we felt we were best positioned was to help augment some of the team-based care efforts through some of our virtual services. Our virtual services are a little bit different than what many of you are probably familiar with because they're wholly owned and integrated. So we have our own captive PC, strictly dedicated to seeing Oscar members. It's integrated into our tech infrastructure, our member service infrastructure, our data infrastructure. And so we can do a lot of unique things because of that integration. And so what we wanted to do was set out to create a wrap with those services around the primary care ecosystems that already exist. And I think one of the challenges that we've seen is a lot of people go into rural communities and try and say, well, we can help with primary care. We'll be the primary care physician. We'll solve those access issues. And I think that, in our opinion, that's not the right approach. These communities have primary care ecosystems. They are trusted. They are established. The key is not to replace those. It's to augment those. And so through our virtual services, we have been able to become an extension of the existing ecosystems. And one example where we've been successful is we've set up a virtual transitional care clinic. Very difficult to get in to see a primary care physician after a patient gets discharged from the facility. And yet with our virtual services, we can see them 24 hours, 48 hours. We can see them every 2 or 3 days if needed until we're able to safely and successfully transition that patient back into the community. So really looking at ways where we can augment the existing resources on the ground.
Thank you for sharing that. I think that's so very important. All healthcare is local, and so truly building upon what's in those communities is critical. Aaron, you want to talk a little bit about in Montana?
Yeah, so I'm with the Montana Healthcare Foundation. We're a 501c3 nonprofit health conversion foundation created in 2014. One of the first things that we did when we came into being was actually funded county health departments and tribal health departments around the state to do community health assessments. This is work that's mandated by state law but not funded by anyone. It's work that really needed to be done. And unsurprisingly, given what we knew from sort of statewide statistics, behavioral health issues really rose to the top. So mental illness and substance use, in the top 3 for almost every community. This was unsurprising. We know the state has a high suicide rate. We know that there are pervasive workforce shortages, especially in the rural and frontier communities. And so when we really looked at what we were hearing from hospitals, from health departments, from tribes, the problem broke down. It's much more than just workforce shortages. It's really a fragmented system of care. You might have a psychiatrist that serves a multi-county rural area. That person's booked out for 3 months, so can't see anyone urgently. And then so what happens? They end up in crisis. They get driven across the state to the state hospital, which is really not ideal. So when we looked at what the system of care needed, we thought we had to start with primary care. There were already FQHCs doing good behavioral health integration, but they didn't serve a lot of communities. We knew that rural health centers, the tribal health departments, and the hospitals, even in larger communities that run a lot of the primary care practices, needed to be looking at this model. So we started, a foundation can make grants, we can provide technical assistance, we can do policy analysis, and we kind of applied all of those tools to this situation. We started funding primary care providers, the ones that see most of the Medicaid patients in the state. That was really where we started our main focus, to implement integrated behavioral health. And as we've been doing this now for 10 years, we've reached a penetration of roughly 80% of the attributed, Medicaid lives, both adult and children, are now seen in a primary care practice that's doing integrated behavioral health. I think what we've learned is it looks very, very different depending on where you are. So, Montana's a big state. 4th largest by geography, not the 4th largest by population. We have just over 1 million residents, so it's kind of like this room. It's all spread out. What works in a primary care practice based at a PPS hospital in one of our urban areas is very, very different than what works at a rural health center that has maybe one nurse practitioner trying to see patients with one MA. And then the tribes also have a whole different set of constraints and challenges that they're facing. So each of these practices looks very different, but we've really seen a ton of innovation. So first of all, as far as the workforce shortages, these providers that we're working with, it's somewhere north of, I think, 80 different sites around the state, have hired dozens and dozens of behavioral health providers, even the rural ones, and they're using them creatively. So the basics of this model are beginning to screen your patients routinely for, for depression, anxiety, SUD, then attempting to create a system where you have warm handoffs to a behavioral health provider when needed. And sometimes, so if you're serving a, large network of rural health centers in a far eastern part of the state, which is very rural, you might be sharing that provider across a few sites. So the handoff might not be quite as warm, or you might augment with telehealth. Whereas, in the urban areas, we're seeing teams really able to bring on and put together a true, kind of more typical behavioral health integration model. I think what we've seen is we're a little bit of a connector, and I heard this in the alignment panel earlier in the day, a connector between payers that have really endorsed behavioral health integration in Montana. There's a lot of support. We were a primary care plus state, and the payers kind of united around some behavioral health related quality measures. But we work with each practice and kind of meet them where they are and try to help them build this model of team-based care from the ground. You asked about the challenges. I think our biggest challenge is really defining, paying for, and measuring care coordination. You can build the best practice imaginable, but if you're not getting people in the door because of whatever barrier there may be, maybe it's untreated depression or substance use, maybe it's a transportation barrier, maybe it's a mobility barrier, the care coordinator really is the person that we've found makes that practice work well and serve the entire community instead of just the people who happen to show up. And yet that's the piece that's not reimbursed well in a lot of payment models. So care coordination is the one that we're working on the hardest.
Thank you very much for sharing that, and certainly agree with you on the care coordinators. We've seen in Arkansas, we design all of our value programs because of so much benefit we've seen there. We are always keeping some of those value dollars towards care coordination and calling it that very thing, because we've seen in some cases, if that goes away, the care coordinators go away. And so it's important for us to keep that in place. All right, I'm going to go back to you for a minute. You talked a little bit about where you're headed in the future, but can you tell me a little bit about how is CMMI thinking about designing models that meet the needs of rural patients and practices specifically?
Yeah, we have a couple of those in our portfolio, as it turns out. We have our Pennsylvania Rural Health Model, and we had our Community Health Access and Rural Transformation Model, or CHART. And PARM is currently running and scheduled to run through December of 2025. And CHART, as some of you may know, or all of you may know, unfortunately was not able to attract hospitals when we opened it for applications, and so had to be terminated in advance. But both were designed to reduce health disparities. They were intended to increase access and quality of care and to improve population health and lower spending. And we've learned a lot. Even from CHART, we learned a lot in developing it. We learned a lot in opening it up for applications. And we're learning a lot from PARM and continuing to learn. And so we're going to take what we have gotten from those models, what we heard through the hackathons, and have learned from those really important engagements, and use that in thinking about future models in the rural space. The other thing to sort of keep in mind that really comes into play when we're thinking about rural models is the requirement that our governing statute has regarding cost savings. We are required to develop model tests that generate cost savings or at least maintain budget neutrality. And so when you think about models in a rural setting, that is really challenging to do, because most often what's needed is some investment in the community. And you're talking about providers who are going to be participating, who are already working under really constrained resources within really thin margins. And so we need to be mindful of that and continue to think about how we can innovate and be creative in the space. And we are very much committed to doing that. And some of the things that we're thinking about with regard to that are trying to find ways to tailor the payment and care delivery elements in our models so that they better support what rural providers need. And that might look like providing more visibility and predictability around revenue. It might mean looking at how we can provide both upfront payments and payments through the model lifecycle that can be used for startup costs, for investing in infrastructure. And then also, as we're developing new models, thinking about whether we can create tracks within those models that really address and speak to the needs of rural providers so that participating in these models looks attractive and hopefully sets them up for success.
Thank you for sharing that. And also, I appreciate the discussions today. And as you've mentioned here today, some of our best lessons are from some of the areas that do not maybe always work, and to carry those forward and for being able to admit that. And I encourage everyone that innovation's all about wins, but it's also about those times that it doesn't work so we can have success from those lessons. So thank you for that. Sean, I'd like to move back to you for a minute and talk about, like, what do you see technology's role in standardizing, data exchange, and or AI playing in addressing the rural health challenges in the different areas of the country?
Yeah, so obviously it's critical. It's a critical component, as I mentioned earlier, just to value-based care in general. But I feel a little guilty because usually you invite the Oscar guy, ask about technology, you're going to expect some about AI or next level things. I don't think that's what we should be talking about right here, because I think the longer we ignore, I think what both Aaron and Ara mentioned, and that is that the foundational basic capabilities needed for these types of things, the rural communities are falling further and further behind the rest of the industry relative to value-based constructs because they don't have some of these basic capabilities. And so things like we've heard, like workforce, right? Team-based models, even the construct of a team-based model, you think about resource-rich environments. The question is, how should we form our team? We have all of these different clinicians and provider types. Who do we want on a team? How does it work for us? You go into rural communities, there are counties that don't have a provider. What is the team going to look like in that case? You have certain places where behavioral health might be the prominent theme. Maybe in those cases, the team should actually, as we heard on an earlier panel, stem from behavioral health. That's actually your primary care entry point. Another one I think about a lot is like dental care, right? I had patients who wouldn't for the life of me, I couldn't get them to come in and see me, but they'd go to their dentist every year. And they'd say, well, because my teeth hurt. And like, you just tell me to lose weight. And like, and so could we use, dental services as an entry point? Do we need to think about teams differently? Do we need to think about workforce differently? And then basic things like broadband. How are we going to put advanced technology out into these communities if we can't even get them basic broadband, basic data sharing infrastructure? Forget moving around mass data sets and making sure people have the right access to data that they need at the point of care. These folks can't get basic data sharing access. And so I am hopeful that technology will eventually play a role. I think it will be important in the future, but I worry that if we don't focus quickly on getting the basic foundational infrastructure into these communities, that they are going to continue to be left further and further behind. And it will be difficult to bring them along in the way that we want.
Thank you very much. Aaron, I'd like to move to you next. We've kind of talked about it a little bit on our panel today, but rural providers and the communities are faced with unique challenges, including the workforce shortages. What are providers operating in rural areas overcoming these common challenges to transition to value-based care?
Yeah, I mean, I think I alluded to one of them earlier, which is, that although we've had workforce shortages, they're just sort of the background of this work in Montana, and it's longstanding and quite severe in a lot of rural communities. I think the practices we're working with have had much more luck than we expected recruiting the providers they needed. And, when we talk to them about why that is, I think part of it is it feels better to work on a team. than to work out there by yourself. And I think for both the primary care providers and many of the behavioral health care providers, if you're serving this spread out population with high needs and you actually feel like you have a little bit of infrastructure and colleagues and a team to take holistic care of the patient, like someone this morning said, putting the head and the body back together, I think you go home at the end of the day feeling a little bit better. So that's our idea. We don't, in fact, know why people are actually able to recruit as well as they have been with this initiative. We provide startup funding, 2 to 4 years, that's it, and maybe that helps. They can offer an attractive salary, but it's been remarkable to see the workforce piece. And we've funded some training with the universities, so now there's integrated behavioral health training with the School of Social Work and professional counseling, but I don't think that's not enough of a pipeline to see what we're seeing. I think it really has to do partly with just the fact that this is an appealing, attractive model for people. I think the other thing we've really learned is that in smaller communities, it is all about partnerships and partnerships that you might not think of. So one of the places we've really focused on behavioral health integration is in prenatal and postpartum care. One of the things I heard when I first got to Montana 10 years ago and started just talking with people is out in rural communities, drug use in pregnancy was a surprising #1 concern for quite a few of the providers delivering babies. So we actually funded some pilot projects. They were not by our design, behavioral health integration focused, so bringing a behavioral health provider into the prenatal care setting, screening everybody and beginning to provide supportive care instead of kind of judgment and stigma and how could you, and it's really transformative. But they did that also recognizing these families need more support that you can provide in a 15-minute clinic visit. They need support from all of the community organizations that serve families. And so, we've really, we now call this the Meadowlark Initiative. It's behavioral integration in the prenatal care setting, but each of those sites creates a community team. They work with their county health department or the tribal health department and then other service providers in the community to really create a community-wide team that can deploy resources as needed for each family that comes into the program. And that's been very powerful. So I think really bringing communities together, and I'd emphasize that the county health departments are often an untapped resource. They are conveners. They're great at bringing together all the parties, not just the healthcare providers, but everybody else that might have something to contribute, having community conversations and getting people aligned and moving in the right direction together.
Excellent, thank you, that's great work. Angela, I'm going to come down that way and ask you, so what solutions should be considered to address the present state of the deficiencies in rural healthcare delivery?
Thank you. So first of all, I'll say I'll agree with everything that's been said here today. And clearly there are pockets of great work across the country as you look at certain areas and agree with the community involvement and local solutions. Being a member of PTAC for the last 6 years and trying to move us to the 2030 vision of all Medicare patients being in an accountable relationship by then, we decided to focus on rural health as a topic. And so we hosted a 2-day event. We had ASPE and NORC do extensive literature research and extensive evaluation of the information that we could gather from CMS and others. And then we invited people from across the country that were in local, rural and frontier markets, payers, policy people, et cetera, and spent two days, working through discussions, heated debates. It was a great 2 days. The PTAC committee walked out of there startled with a sense of urgency, because although there are areas and initiatives going on, while those are doing great work, it is at a national level nibbling around the edges, as we put it. We actually put all this in a letter to the secretary and sent that, which is publicly available. So despite these efforts, from 2013 to 2020, there were 100 rural hospitals that closed. And in 2023, there was an additional 11. Today, there are 600 rural hospitals that are at risk of closing. And so, that's a startling fact. And then when you start to look at the patient populations, it's 15% of our population. And all of those, just as you said, actually their life expectancy is decreasing. We're not improving their life expectancy, they're decreasing. Their chronic disease burden is significant. They don't have the resources. They don't have the transition to care processes. 50% of the rural counties aren't even adjacent to a metropolitan area. And so there's a lot of issues that need to be resolved. As we looked at potential solutions, and everybody's trying to create, small projects to address certain things, the things that stuck out to us was the PARM. I mean, the Pennsylvania Rural Health Model with that central authority center that can help organize, create relationships in the community, create funding, I think is a model that we need to consider for the entire country. Working with the Pennsylvania State Department of Health and CMMI, I think that's a great model. One of the issues, though, is that as we looked at those populations, there are not enough Medicare patients in those rural areas to sustain a value-based payment model and solve all these problems. So this has to be a multi-payer project, and it has to be a multi-agency project. It can't just be CMMI can't solve all these problems. The state agencies have to get involved. Other federal agencies have to get involved and help with that funding, help with that coordination. The idea of rural emergency hospitals as opposed to rural hospitals, paying them in a way that they have to have a plan so that the hospitals, the ED docs, the primary care docs have to have a common incentives to keep those patients well and out of the hospital. And that there's either direct funding or wraparound funding models for the community-based organizations, for community health workers, for those kinds of things where there's actually an ability to sustain those kind of models. We think that unless something like that happens, we're going to continue to see certain rural areas just not thrive. And although there's certainly superb programs going on in very local markets, it's not scalable unless what I just described happens. So.
Thank you for sharing that. There's definitely an urgency across the country. At this time, we'd actually like to open it up to the audience. We've got microphones here in the aisles. If you have any questions for these wonderful panelists, please step up to the microphone. And I apologize, the lights are really bright.
I'll help you out there.
Thank you.
Yeah, Bill Golden. I've heard a lot about mental health. We've heard a lot about primary care. Didn't talk a lot about obstetrical deserts and perinatal care, which is also a major issue. Do you have any vision about, do you integrate early prenatal care into primary care, and how do you support them? What's your approach on this item, since maternal morbidity and mortality is such a pressing issue?
Yeah, I'm happy to start. I think we've been lucky to not have any of our current obstetric hospitals stop the practice. So we have, we have a network that puts patients in most parts of the state within, an hour and a half to 2 hours, maybe, of a delivering hospital. If we lost any, there could be catastrophes, much, much worse than that. So one of the things we've actually heard, our state is a Medicaid expansion state. Medicaid expansion is up for renewal by our next legislature starting in January. A number of the critical access hospitals that still deliver babies do so at a loss and say that it would have to be one of the services that they would consider cutting if they lost the revenue from Medicaid expansion. So we're very worried about that. It's a big deal. I don't think we have a model to solve it. I do think that what we've seen is these practices that are doing behavioral health integration are actually getting people in for care more regularly. And so their revenue goes up when that happens. So that's something that we hope to really build on. A number of the hospitals that actually paid for care coordination out of their pockets also saw, no-shows go down, revenue goes up, and so they're actually able to sustain that without our grant funding.
Yeah, and to clarify just a little, I was not as much interested in the delivery of the baby, but the actual early stages of management of prenatal care as well.
Yeah. A lot of the primary care providers in the state will do prenatal care up to 18 to 24 weeks. And that's wider spread, but I think where we hear about problems are more, people who in winter have to drive, 2 hours in labor. That's terrifying for people. So.
And I would make the argument that prevention of perinatal morbidity begins 9 months before delivery. And so I think the notion of making sure those patients are receiving that care during their pregnancy, either through doulas, through community health workers, through the model I just got through talking about, so that you're identifying those patients. Because most of those patients with high perinatal mortality just aren't getting services, and their diabetes is out of control. There's all kinds of comorbid conditions, and when they show up for delivery, their baby's not going to make it. Sometimes they don't make it. And so I think the focus on that prevention beginning 9 months before that delivery is the key. Yeah.
I'll probably even get a little more conceptual. It's the thing that I'm probably most heartened about, and also for the thing that I think is going to be the greatest challenge is we are going to have to create models that are flexible enough for the communities to decide what they look like to some extent, because rural communities are widely heterogeneous. We were talking backstage, we talk rural health, well, frontier health, tribal health, general, even those have very different needs, very different capabilities, very different resources, very different care models. And so I think one of the things I was most heartened, this is how nerdy I am, y'all get to see, is I read this report. It's a great report, by the way. I'll make a plug for those of you who haven't had a chance to read the report that was just put out on rural health. It was something like 25 or 26 times the word flexible or flexibility was mentioned in this report. It's like an 18, 20-page report. And that's exactly right. We have to enable the communities themselves to understand their own needs and be their own solution. And then we need to be enabling for that, right? And so the answer very well may be, and well, it depends. What community are you talking about? What resources do they have? How might we enable that community? Because I agree with what everybody said, you got to get way upstream, but how any individual community does that might look very different.
Thank you very much. We have a next question.
Yeah, hi, I'm Daryl Roberts with Rely Group. First, I want to make a comment, and then I've got a question. The comment is that when I was working as a bedside nurse in labor and delivery for a very short period, the way that we focused on labor and delivery and on perinatal care was around the average 20 to 35-year-old mother who was pregnant. Mothers are getting a lot older, and they're having a lot more multiple chronic conditions than really the paradigm was designed for. And I just want to hope that the policy people up there are focusing on that new paradigm. My question, though, I live in this little town called Washington, North Carolina, the original Washington, by the way. And it's a blessed neighborhood community because we have East Carolina University just down the street. So, we can get access to good care in a rural area. Not too far away from us, though, are other towns that are further and further out in the inner banks of North Carolina that are. I was sitting in a pub in Washington, listening to folks talking about telehealth, and I noticed you haven't talked a lot about telehealth, but they have actually got concerns about telehealth. That because telehealth is being delivered in their areas, they're not going to get a new clinic. They're not going to get new docs. They're not going to get a new pharmacy because telehealth is going to be delivered, which to them was very disheartening. It's a group of older gentlemen that have a beer every Thursday night at this pub. And they said, well, now we're not actually going to be able to see a real doctor. We're going to have to see a telephone or a tablet instead. How do you respond to that?
I'll start because I think that's exactly what I was trying to address earlier with some of my comments is we have to maintain the primacy of the community care ecosystem. It is so important, and it's established, and it's trusted, and it's local, and it's all the things that we all, I think, know and believe are critical for longitudinal care coordination and strong patient-centered care. I think where technology is going to play a role is in augmenting that, right? Going back to what I was saying, when we think about care teams, it's going to be very difficult. And I think your comment about kind of the room and everybody spread out, well, that's also the way the healthcare providers are, you know? And you're not going to get hyper-concentration of healthcares to create the teams that you might see in resource-rich environments. That's where I think technology can be an augmentation, but as an extension. So it's not coming from, oh, I'll just go to the telemedicine guy and he'll take care of everything I need. It's you're calling your primary care physician who might be 45 miles away. Say, don't come in. Why don't you give a call over here? Someone works with my clinic. I'll make sure I'm overseeing them, and then we'll get you what you need, and then you don't have to make the trip or whatever the case might be. So I think we have to be very thoughtful about the way we build teams. I think we have to be thoughtful about how we deploy technology while maintaining the primacy of the local ecosystem.
And I'll just add to that I think that while the hackathons were our attempt to really get input at a local level, to hear from experts who are delivering care on the ground, the patient's voice is also extraordinarily important in what we are pursuing and thinking about as we're developing models. And so we don't want to lose sight of that, even as we're making sure that we pull in the individual local needs, local preferences. So I think to Sean's point, like just making sure that as we're thinking about models and as we're designing them, that we have the patient at the center of what we're doing, and that we're also keeping in mind the preferences and the particular needs of the region, the area in which the care is being delivered.
I think that's a great way as we summarize what we've gotten here today. We certainly have heard the patient center, the patient voice, the provider burden, looking at shortages across these rural areas, but being flexible in those local communities and understanding who is the voice that can help drive the change and the leadership to make a difference. And I think one of the things I'll ask all of you out there is we all have an opportunity to support and improve this type of care in the communities. And so I'm challenging all of you to take something back that you've heard here from this wonderful panel today and try to make a difference in your local communities. So please join me in thanking these wonderful panelists today. Thank you all very much. And what I'll ask you is please fill out the survey. We do want to hear from you. It's very important for us to hear from you and to be able to make your feedback a reality or change for the future. So thank you all very much.